Nutrition science evolves through milestones, moments when evidence deepens and practice transforms. Welcome to Milestones in Pediatric Nutrition, a podcast by the Nestlé Nutrition Institute, hosted by Professor Andrew Prentice. In each episode, leading experts reflect on breakthroughs that shape modern nutritional care, from early life feeding to practice-changing interventions across the life course. Because progress happens, one milestone at a time. This festive season, join us as we celebrate the discoveries that continue to improve children's health worldwide. Welcome to Milestones from the Nestlé Nutrition Institute, your daily dose of breakthroughs in pediatric nutrition this holiday season. Today, Professor Andrew Prentice is joined by Dr. Mercedes de Onis to discuss WHO growth standards, how global growth curves transformed assessment and policy, a milestone shaping the future of child health.
Hello, my name is Andrew Prentice, and it's my huge pleasure to welcome you to our podcast series, Milestones in Pediatric Nutrition. This is part of the wider series of NNI Bites Big Learnings. Now, in this new series, I talk to some of the world's leading scientists and policy advocates about discoveries, interventions, inventions that have made a real impact in improving pediatric nutrition. Today's milestone is an especially important one, the WHO Child Growth Standards. Indeed, it's fair to say that it was this topic that set me thinking about doing a podcast series on critical advances in pediatric nutrition in the first place. We all use the charts, but who amongst us knows the history behind them or can fathom the blood, sweat, and tears that must have gone into their making? Well, that person is our guest today, the mother, if I may put it that way, of the WHO growth standards that are used in over 150 countries worldwide. Dr. Mercedes de Onis, welcome to today's podcast.
Thank you, Andrew. It is an honor for me to be in this podcast.
Now, I have to tell you, listeners, that dear Mercedes is in hospital with a very broken foot following a car accident. So we're enormously honored that she's been brave enough to do this podcast. Thank you very much indeed.
You're welcome.
Dr. de Onis trained in medicine in Madrid and then completed her training in public health and epidemiology at the world-renowned School of Public Health at Johns Hopkins University in Baltimore, before then moving to NIH to complete a PhD on fetal growth retardation. She was then, I'm not sure if it was your first appointment, but she was then appointed as the coordinator of the Growth Assessment and Surveillance Unit at WHO in Geneva. And it was in this capacity that she initiated the work that we'll hear about today. Although carrying important policy responsibilities throughout most of her working life, Mercedes kept her foot strongly in academia and has published many seminal papers, no fewer than 15 of which, and this makes me jealous, have become citation classics by being cited over 1,000 times. And when we say cited, we mean quoted at the end of another paper that someone else has written. And the paper describing the growth curves has been cited over 20,000 times. Mercedes, let's start with the simple question of why do we need growth standards?
Well, growth standards are important both at population and individual level. At the population level, they allow to see the rates of undernutrition and overnutrition of populations or countries, and they allow also the comparison of across population. At the individual level, which are very much used by pediatricians and healthcare workers all over, they serve to identify early growth faltering and therefore to put early interventions.
Early clinical interventions, nutritional interventions, or to look out for the underlying causes of growth faltering. And so, as you've indicated, they're enormously important and have probably, well, we'll maybe talk about this later, but I imagine that they've saved many hundreds of thousands of lives, probably. So there was a crying need for better reference standards because at the time that you started this, before the WHO growth standards, there was a time when most of us used what were called the NCHS curves. What was the problem with those, Mercedes, and similar curves such as the UK standards?
The problem was we were receiving a cry from the field, constant communications of the problem of it is in the first year of life, that children breastfed seem to falter at 3-4 months of age, which made recommending mothers to decrease breastfeeding or stop breastfeeding altogether, which is extremely dangerous in some environments. Another complaint was that they were based on American children, which people were uncomfortable with comparing their children from whatever, Namibia, with American children. And I just had arrived to WHO. I was young and naive, and I had nothing to do, literally. Nobody told me what to do. So I decided to do this, talking to the NCHS. NCHS recognized, which is, let's call it the American reference, recognized the problem, but they could not offer any solution to it. So that's how I started thinking about doing a multi-country study.
Let's just dwell on that issue about breastfeeding a little bit, because just to underscore the point you made, if a breastfed child is growing less well than what is taken as the standard of the time, then obviously that undermines the whole concept of breastfeeding. It looks as if most breastfeeding children are not growing well, which, you know, was super critical in terms of the potential of undermining breastfeeding. So that, I'm glad you brought that point up. It was really important, and I'd forgotten that one. So, Mercedes, I think from what you're saying, it was your idea to conduct a multi-center study to gather the requisite data.
Yes, I remember one day I opened the door of the head of the nutrition department, and that Dr. Alberto Pradilla, that had an enormous impact on me. And I sat down and discussed with him this. I remember he was smiling at me and telling me, okay, go ahead, but if you are going to do it the best you can, do the proper protocol, even if it is difficult, and do it in various countries. So that was it. I went ahead.
I bet you regretted that many times after that.
I do, actually. If I had known the pain, I would not have done it. I am very honest with this. It was very difficult to do it in 6 countries with so many different languages and cultures and everything.
Now, WHO is often short of money, and unfortunately, in this day and age, even more short of money. But who funded the study, Mercedes?
WHO funded my salary. That was it.
Mm-hmm.
So it was mainly governments. Let me tell you, the government was the government in Europe, the Netherlands, and Norway. In the US, North America, the US and Canada. Then the government of Oman and the government of Norway, they put a lot of money. But the main donor was the Bill and Melinda Gates Foundation.
Wow. So that was in the very early days of the foundation.
Yes, I think so.
Indeed.
I think so.
Okay. So late 1990s, everything was getting in place for the now famous WHO Multicentre Growth Study. And I just want to run through the countries. You had carefully selected cohorts in Brazil, Ghana, India, Norway, Oman, and USA, if I'm not mistaken. What now were the principles used for selecting, first the sites, and then the participants within those sites?
Well, selecting the site was to overcome this uneasiness of using the American children. Mm-hmm. And so I went to go through different geographical regions. That's why South America, Brazil, North America, the US, Europe, Norway, Africa, Ghana. Then we have Southeast Asia, India, and East Asia, Oman. We did have China also for the Western Asia, but China dropped very early from the study. They didn't even start the study because they said the protocol was very difficult in terms of the breastfeeding, that mothers in China do not breastfeed.
So, okay, we've got the sites. Now, you've already indicated that it had a
for
difficult...
the individual, sorry, I forgot that part of the question. They had to be mothers that did not smoke during gestation and not intend to smoke during lactation. there were mothers that have the intention to follow the WHO breastfeeding recommendations, which is exclusive breastfeeding up until 6 months, and introduction of complementary foods by 6 months of age. And then there had to be mothers from environments that did not impose constraints to growth. So where children were followed by pediatrician with vaccines, correct sanitation, etc.
Did you have anything about the sort of economic status? Were these basically, I suppose
Yes.
they were almost middle-class women by definition if they've got good sanitation and so forth?
Yes, that was the case. For example, in Norway and the US, there was no cutoff of anything. And Brazil was based on education, so was India, very high level of education of mother and father. Oman was sort of middle class, and Ghana was also high level of education. But we did conduct separate studies for this.
Yeah. So, and I know that with just thinking about those sites again, I know you built very many friendships, and actually you launched, I think, the careers of various people through their involvement in your multi-center study. So well done.
Well,
for
let
that
me
as
tell
well.
you, the teams were unbelievable. I had two superstars of research, Cesar Victora from Brazil and Kay Dewey from the States. And then I had people that knew nothing, literally nothing about research. This was the government of Oman and the government of Norway. But they were so committed and so enthusiastic and so into it that we interacted. I mean, we support them more than the others. And in fact, Brazil started first because Cesar we decided that he should, one of the good sites, I mean, meaning the US or Brazil, should start first the study to test it. And in fact, we did change some things when Cesar started in 97.
That's fantastic. And I mean, those, as you said, are seminal researchers and have done so much in bringing others forward. Who was the lead in Ghana? Was that Kay Dewey?
Anna Larte, which was a student of Kay Dewey.
That's what I thought. And Anna Latte, for those who don't know it, then became extremely famous to the stage where she became president of the International Union of Nutritional Sciences and a very senior leader of FAO. So you really set a lot of people on fantastic trajectories. Well done for that.
Thank you.
Now, over the next 5 years or so, the study was completed, but I think we shouldn't shortcut and get to the end yet, because I'm imagining that you said you had a very complex protocol and a very detailed protocol, but I'm guessing that you also had training meetings and so forth to pull the teams together.
For anthropometry, which was the key indicator, we have constant, every 2 months, we had a gold standard, which was Professor Noel Cameron, traveling from site to site as a standard, and we conducted the standardization. And we have a paper presenting all of this for the reliability, and which I think makes the study very robust, showing similarities. From Oman, we got one standardization was so perfect, so exact, that we went there and realized that the health workers that work in pairs were blind one to the other, were sort of cheating.
Yeah.
And they had to restart. I mean, we discovered this very early in the study, I think in the first standardization. So they had to restart. Made the government very angry, but anyhow, we made them restart, and they did restart.
This is like an epic novel with all the things that went on, and I can just imagine what a burden and a toll it took on your life. But I've had similar examples like that. I mean, in some of our work in the Gambia, you have also people, I'm not sure what the term is, but they either, when they're measuring a child, they either put a 0 at the end or a 0.5 at the end instead of the precise number that is what you really want. So that happens a lot as well. Okay. I should say, before we move on to the next bit, that Kay Dewey is already booked for one of these podcasts, and Cesar Vitora is absolutely in my sights, and so is Anna Latte. So you've mentioned some real seminal names there. Right. So over the next 5 years or so, the study was completed. The data were in. And what next? I'm thinking about the statistical methods used and how you set the ranges for healthy, less healthy, and unhealthy.
Well, we found, luckily, we found that the growth of the children in the different sites was strikingly similar. So that allowed us to combine the 6 sites and gain a much serious sample size. And then we follow just the standard nomenclature of standard deviation, plus minus standard deviation above and below the mean. And that in doing the standard, it took us 2 years to do the standard. I understood nothing because this was like Chinese to me, really. But there were committees with very serious, with a lot of experience, like Tim Cole from the UK and others that were very experienced in doing this. Plus I had 3 statisticians in Geneva, which was unheard of, having 3 statisticians in the same unit. And anyhow, they did it, and it was correct, but it was, and then we tested them. That I have good souvenirs because we tested them in the Maldives. That was a fantastic place to test the standards.
Mm-hmm. You had a few weeks in the Maldives, did you, doing it?
Yes. Yes, they put us on a boat, and we went from island to island.
What a good choice. Okay. Do you want to call out your chief statistician, who I know you owe a big debt of gratitude to? What was her name?
Yes, it's Elaine Borgi. Is a statistician from Brazil, trained in the US, and it came to the study just as coming out of the university. So she never went back to Brazil, and is still in WHO. In fact, she took my position at WHO and continues supporting although the standards have a life of their own, still they need some support with using Anthro, the software for individual monitoring, or the bits they constructed, the macros to put into the macros of analyzing national surveys. So sometimes they need some support of that sort, statistical support, and Elaine takes care of that.
So the standards were launched in 2006, was it?
2006, yes.
But the job, I mean, that's not the end of the job.
No.
And I'm intrigued by the kind of the politics, the global politics.
That wasn't the end of the job, not at all. But the job, which was there in global implementation, which I did pretty much on my own, was a daunting task, but was easier than expected. Why it was easier? Because the study had been going on for so many years, almost 20 years, that people heard about it and they were like expecting its release and ready to use them. So that make that many countries, they just replaced the American reference by the WHO standards from one day to another. For example, Chile called me and they said, well, the next printing of the birth card go with WHO. And they were all over, including countries like Switzerland. Then there were countries that were more picky, and these were developed countries. This was the UK, the US, Australia, and India. I'll tell about India. These countries established committees with senior pediatricians and statisticians and so on to evaluate the growth standards in terms of the pros and cons that will bring to the country. And after that, the US adopted, so was the UK, and then it came like a rollout of developed countries in the Europe. India was a bit of a pain because they put one committee that resulted in the WHO standard, and another committee, and another committee, and another committee. I mean, and you can imagine how different was the Indian reference from the WHO growth standard. They were complaining in the government that the rates of stunting went out from 4% to 40%, things like that, and that wasn't good. It didn't look good for the Millennium Development Goals. So, but now they use it. I think, I don't know, but I think almost, I mean, except perhaps Cuba and North Korea, I think all the rest of the countries use it. Definitely most research papers are using the WHO child growth standard. So it was a lot of work, but it was worth it.
And this is what I love talking to you, why I love talking to you, because, I use it all the time. My team uses it all the time in our research, in our papers, in our teaching and so forth. And yet, we don't really think so carefully about where it all came from and the effort that went into it. So that's interesting. Although there was a huge amount of work, the path was oiled, if you like, and ready, and they were adopted mostly readily, with the exception of India and then the tardiness of UK and US, as you've described. Now, we're sort of coming towards the end of our time, but I think we should tell listeners who are unaware that some years later, your same model was used to generate fetal growth curves. And if I were in your shoes, I would be so immensely proud of what I and my team had accomplished. But let's go a little bit further in terms of explaining to listeners some of the breadth of the impact that the standards have achieved.
Growth monitoring, the follow-up to Millennium Development Goals. There are also new standards that did not exist before. For example, body mass index and tricep and subscapular skin folds. These are important to monitor overweight and obesity. There are also the velocity standards. These are much less used, but I think they are much less used because we do not know how to use them. But I think once we know how to use them, there will be very good results, because growth is very rapid. Growth velocity is very rapid in the first 12, also 24 months. Then it sort of stabilizes a plateau, reaches a plateau. So I think once we know how to, which we have tried to do a lot with Reinaldo Martorell, another important researcher that had a lot to do with the study, I think once we learn how to use them, not me, I'm completely retired, but other younger researchers, there is a lot of future for them. And it's very difficult to construct velocity standards because you have to actually monitor the same children. Look, we measure them every 2 weeks up to 2 months, then every month up to 1 year, and then every 2 months up to 24 years. So it was a longitudinal study that follow all these thousands of children and following the same characteristics, and that is very difficult to accomplish ever again.
Although, as you say, not many people are using them yet. I must say I find them incredibly insightful. For instance, in comparing the growth of our children in rural Gambia compared to those in the UK, you can really see the time points at which this deviates much more clearly than you can from the normal cross-sectional standards. So they're really useful. But yeah, hopefully more people will use those. The BMI standards and the skinfold standards are also hugely important, and perhaps becoming more important as we face a pandemic of obesity, which is penetrating down into the pediatric age range. And BMI curves are so important because you can't just, in adults, we just say, over a BMI of 25 is overweight, over 30 is obese, and so forth. But you can't do that for children because the BMI curves are very, very different and the numbers are different.
Yeah.
Okay, well now, I want to ask you your thoughts for the future. Will we ever need to generate new growth curves? I kind of assume not.
I don't think so, really. I think the effort that went into doing this is difficult to do it better. The standards are of very, very high quality in all senses, in training, retraining, selecting the children, monitoring them. And I think it's very difficult to replicate, but there is no need to replicate. I don't think there will be, maybe with the international, with the IE, other ways of monitoring nutritional status, but with anthropometry, this is it.
I agree. And I think it would be, really counterproductive to start messing about with new ones, because then you move the goalposts and all your historical data, is difficult to compare. So I totally agree with you. And therefore, Mercedes, today's milestone is not just an important marker along the way of progress, but it's actually the summit, I would say, a really true milestone. And with that, Dr. Onis, it remains me to thank you, for your life's work in creating a very cornerstone of pediatric nutrition.
Thank you very much.
This directly or indirectly influences the care given to billions of children worldwide. It's been a huge pleasure to hear your story and to sort of feel the effort, the challenges, the toil that went into it all, both from you and your wonderful team.
Mm-hmm.
It's been a huge pleasure talking to you. And listeners, thank you for joining this edition of our podcast, like Milestones in Pediatric Nutrition, part of the NNI Bites Big Learning Series. Please subscribe to us through the NNI website or the NNI 365 app to make sure that you don't miss the future offerings.
Thank you for joining us on Milestones. For expert-led discussions, scientific publications, and educational resources, visit the Nestlé Nutrition Institute website. Follow us on our social channels and subscribe to never miss an episode. Join us again tomorrow as we take nutrition science further, one milestone at a time. Wishing you a season of learning and discovery.